Good afternoon, everyone present here. Myself, Rohan Valse, and here is Rucha Rakne. We both are senior secretaries of Medical Humanities Department, and we are all thrilled to show you this event and hope you take something home from this event. Uh, so, before starting the event, we'd like to show you a glimpse of what our Medical Humanities Department does. So, we'd like to show it to you through a video.
It is a remarkable thing that you have done to set up that Department of Humanities, that we prefer to call it Humanities Department of Medical Humanities. It is really a very important aspect which has been missed out in not only the city and our country. My proposition today is that the awareness and particularly an acquaintance, if not a deep study of the humanities, makes a better physician. And what exactly do we mean by humanities? Well, it includes history, it includes ethics, it includes literature, poetry, philosophy, religion, perhaps social sciences, art and culture, the visual arts, poetry, drama, and himself.
Billions of America and age they are. Look at those accessories and look at the basis have. It's surprising to see so many all the organization services. And then they got those things. We have what? So the warning from what comes to the year. So what happens to service? In the middle one, you go more than one. And what do you do? If you get out, you come to the end. If you get out, you get all one. You will know that the warrior is having good this time. But if you saw, this was the more to share, more to share. Everyone has got a certain power. If you share, so if you stop looking at your classes and your computers, you look at each other's strengths, and you have issues.
And now if you draw a sketch of the world and finally mobile phone and just see everyone. This concept is the same, but now you are expressing and you are showcasing an alternate way of looking at it. Yeah.
And समाज को जारी रहने का समय है. Awards, rewards are welcome and incentive to work harder. But the best reward is the smile on the patient's face and the knowledge and satisfaction that you have touched somebody's life and made it better.
Now, without any further delay, I would like to call upon Dr. Vinita Puri to share her experience.
Good afternoon, everyone. So I don't know how happy you people are to be here listening to me, but I am simply thrilled to bits. I'm feeling very happy sitting among such a young crowd. This is the first time I think this is the first time I'm talking to first MBBS students. It's a really long time. One of my staff was just now saying you must be feeling like a fossil, and I do feel like a fossil sitting talking to all of you. But I hope that this lecture is of interest to you. I don't know how many of you know about the hand transplant, not the one we have done, or anyway. I guess all of you know about transplants. That should be the basic, right? When we say transplants, we mean that you put an organ from one body to another. Sometimes they are live donors, that is, especially in kidney and liver, you may have heard that a family member donates or somebody else donates a kidney. So I think kidney transplant is the most, the common one across. But here today, what we are going to talk about is a hand transplant and our journey to the first hand transplant in KEM. So there have been very few hand transplants. You can say that you can actually count them, easily in among hands, you should say. In India, the first hand transplant in India happened only in 2015, January of 2015, and that was in Amrita Institute. Somewhere in 2016, we actually got our license, though we went ahead and did our surgery much later, simply because it is not that easy to get, hands don't come by that easily. And in between, by 2020, COVID happened, and then our patient who was registered also went away to his native place in part of the migration, because we deal only with the poor. So our hospital is only the 5th hospital which has done the surgery, and finally in August of 2021 we went ahead and did the surgery. Now, why is it that we dared to dream and say that yes, we could do this in KEM? It is not very easy. There are barely, I think, a total of probably 17 or 18 transplants have been done in our country. Ours, I think, was the 12th or the 13th one. Not a very easy surgery, and it needs huge teamwork to be able to do it. So how did we make it possible for this young 21-year-old boy is the story what I will tell you today. There will be probably some extra ways that I will tell this story, but let's go ahead. So when you look at KEM, I don't know how many of you know that this is actually a photograph of KEM. Little Photoshop has been done. This has been taken from one of the heights from Tata Hospital, one of the tall building of Tata Hospital. And what you see in front of you directly in the middle, and that is the main campus of KEM. And you see that it is completely dwarfed by all the tall buildings. So vaguely KEM feels like that, with all facilities available but dwarfed by all the corporate hospitals that are there, and you feel that all good work happens only in corporate hospitals. So now, why is it that we felt that we would be able to go ahead and do a hand transplant? Why did we dream about doing a hand transplant in our institute? One is that I think our institute is very capable of doing this. We are also capable of providing something which is so expensive. If you go outside and you're going to get it done 25-30 lakhs per case, and we feel that it is possible to do everything for the poor in our hospital. And we felt that we were very much capable of doing this surgery. As plastic surgeons, we felt that we had the capability of carrying off such a huge task. Why did we feel that? You see this photograph, this is a patient whom I have done 20 years back. He was a railway accident, he had fallen off the train at Andheri station. In fact, I remember that month, March of 2001 from what I recollect. He had, and we had got two such patients from the same station. He was a laborer and I put it back. So if you realize, cases like these are way more difficult than doing something in a cold environment and in a, you know, in a place which is controlled. So these are for some of the cases. Another one which was a complete avulsion of the hand, and this was a young gentleman again, and there was a lot of shortening that needed to be done, but he went back with a hand. Here is a young girl, she was barely 8 years old, somewhere in Dombivli, and she had an avulsion injury. Her hand got stuck in the lift, she went off in the lift, and the hand just fell off outside. So this is another one. She went on to do well later. So if you realize that if we are able to do these cases and put hands back together, arms together, and hands at the level of forearm, then we do feel that we should be able to put somebody else's hand also on like a transplant. So this was our surgical experience. So in terms of institute, yes, we as a unit are experienced hand and microvascular surgeons, but we do need good orthopedic and anesthesia support, which is very much there, of course, in our hospital. We have a very good orthopedic department and anesthesia. We need dedicated operation theatres, which the plastic surgery department does have. We literally run 24/7. If whenever you all do internship, you'll realize that ours is more like a small scale industry which just doesn't stop, and round the clock we get emergency care, emergency patients. We our hospital does have a transplant ICU because transplants are anyway happening in our hospital in the form of kidney transplants, and a few liver transplants have also been done, and hence transplant immunology, which is a very important part of transplant, is available to us. Those services will be available to us. Even the other things like pathology, microbiology, all of you, of course, would be going through those subjects later. All that is available. We have our school of physiotherapy and occupational therapy, all of you know that. So hence we have very good therapy services which are absolutely essential for a hand transplant patient, because even if we put everything back, if you're not going to exercise, that hand is not really going to come to function. Now, how did we make our dream come true? Well, we decided to have a we made a multidisciplinary hand transplant team, and then we went ahead and applied to the Directorate of Health Services for registration. So one cannot just get up and say, oh, we have everything available, can we just go ahead and do a hand transplant? You can't do that. A licensing is essential. So we applied for a license in 2016 and we had to be fully prepared for it. There's a huge challenge, and the first challenge that comes is that you need to make a file which is really huge, and somebody needs to run around and try and get all the paperwork from everybody, and that may seem like a simple job, but it's not really that simple. So I had a young assistant professor at that time called Dr.M.V.L.Kothari, and he's the one who ran around and got all the, I think it took him almost 2.5 months to get everybody's paperwork. And when we did our renewal of a license in 21, I had Dr. Anirudh Gupta who did the same at that time. And after that, I should say that we had our inspection. Inspection was a big thing. We had people coming in from the Directorate of Health Services as well as an orthopedic surgeon and another plastic surgeon. They came in, they saw all our facilities. We introduced them to the whole team. They were satisfied and received our license in 2016. Later, we renewed our license. The license is actually available only for 5 years, and it needs to be renewed. So we did that again in May of 21. So what is it about public hospitals that are a problem? So basically our hospitals are huge, and if you see our SOP, when I say SOP, I mean our standard operating procedure for a patient who comes in for a transplant. This is the kind of investigations that are done. You see the investigation, you have general, and you have this huge list. Here you can see up to 8, and then you have it goes all the way, like you need to get a pulmonary function test. Basically you need to make sure that the patient is completely fine. A lot of radiological tests are done and a lot of references are to be done. So it is understood that in huge hospitals and with so much of investigations, tests and references, the patients are surely going to get tired out and they're going to feel really overwhelmed. More overwhelmed because it's not as easy as going to a corporate hospital, because in a public hospital and in a place like KEM, each and everything is in a different place and you're running around. So how did we make it easy for our patient? What we did is that we basically got the patient admitted. So the minute the patient came and he said that yes, I want to get something done, we got the patient admitted, got all the investigations done. One of my resident doctors make sure that they go around with the patient whenever needed, and like with the radiologist, I would go down, somebody else would go, we'd have our coordination with them to make sure that everything is in place. The next thing, so even though we had got our license and we thought everything was right, despite that we felt that it was very important for us to build our technical capability even more, and for that we came and did practice sessions for transplant. So you would say, how would you do a practice session? Very much here in this very department is where we did the practice sessions, and it was more like a reality show. We came to the anatomy dissection hall, and we at that time it was Dr. Bhuya, and she kindly gave us two fresh cadavers. So one of the cadavers became the donor and one became the recipient. And what we did is that our registered candidate, we basically one of the cadavers, we amputed the limb to the level that was there in our actual patient. So we prepared that one cadaver as the patient and the other one became the donor. So here you can see all of us operating, and here on the left you see me, and I am preparing the recipient limb. You can see that it's an amputed stump, and I am preparing all the structures. And the other surgeon you can see is preparing the hand to again the same structures. Now when this is our orthopedic team, the orthopedic team also came over, and here you can see them attempting a fixation of the, so it is, there are many challenges when you're doing a transplant. The size could be different, the muscle mass could be different, there are all kinds of things. So this was, therefore we did mock surgery, and you have to, and all these little like chits are made with all the tendons and the nerves and the bones, and this is what is done. So you see that each and every structure that is there in the hand is tagged. I was telling your head of department here that I'm not going to be teaching anatomy, and right now I'm not going to be telling you all the structures. All I can say that we have two bones in the hand. We have a huge 25 tendons almost in the hand on the flexor and the extensor surface. We have your two main nerves, the median nerve and the ulnar nerve, and you have the radial nerve on the back. Along with that, you have two arteries and multiple veins and huge number of bones, right? But your bones would be fixed. So can you imagine that vis-a-vis trying to do a kidney transplant, where you have a kidney, you just connect the ureter, you connect the artery, and you connect the vein. It's not the same. So technically this is an exceedingly, very exceedingly difficult surgery, where starting from the bone inwards, you go all the way up to the skin, and hence practice and getting ourselves really good is very important. This was the team that did this mock surgery in 2016. We did it again in March 2020, and here you can see the videos of the surgery. This time we had also called one of the surgeons who were the first surgeons who had done it in Amrita. We had also called them just to make sure that we had invited them for this cadaver surgeries, just to get their inputs for the surgical things that we were doing. Since it was a whole 5 years since our earlier licensing, we created a new WhatsApp group, made sure that each person who is part of the transplant team was there in the group. You can see that there are 30 participants. This was very important because finally, when you remember that when you get a call for the transplant, it is always an emergency thing. It is not that it is going to be planned. Obviously, somewhere in some hospital, somebody is brain dead, and their relatives are now willing to donate their organs, and that's how. So that doesn't come with any time stamp. It can happen at any time. So finally came the day at somewhere at 3 a.m. in the morning. I was woken up with a call, and I was told that right, we have a donor, and we have the blood group matched with our patient, and would we be willing to go ahead? So we said yes, and I think by 4:30 I was there, the other surgeon was there, and practically the whole department, all of us came in by 5 or 5:30. We were all there. Then started the wait because we had to wait for other teams to also reach the donor hospital, and it was a lady who had basically for 25 days almost, she had been in the ICU, and she had a sudden probably a stroke, and then she had become brain dead. So the liver was to be donated, the kidney. The family was very kind, and they said that they would like to donate as many organs as possible. So we had to wait because I think the liver team was coming down from Chennai, yeah, from Hyderabad. So we had quite a wait. By the time my team who had gone for retrieval was ready and starting to do the retrieval, it was almost 12:30 in the afternoon. So we then took up our patient in surgery. Now. Teamwork was very important because we cannot just start. We started surgery, but you need to give some loading doses of the immune drugs. So in this case, our nephrology department gave us a dedicated nephrologist who would take care of each and every immune needs of that patient. We had a Dr. Nikhil who was our and to this date he continues to be our first person of contact in that unit. For the transplant ICU, since the yeah. So for the transplant ICU, we use the liver ICU because they also have a liver program. So they have a very good transplant ICU there. The pathology and the skin department also gave us dedicated pathologists for the skin biopsy for these patients. And most importantly, I think nothing is possible anywhere unless until the administration is with you, and the administration, the dean was very much with us, and clear instructions were given to the matron and also to the people who gave us the class 4 workers, and we were given one nurse and one class 4 worker round the clock for just one this patient. And as you grow older in this field and as you all come down to do residency in our hospitals, you will realize what a fight it is to get nurses and class 4 workers because they're always in short supply. So I think the administration was also very kind to us, and they did give us dedicated staff for this one patient. Next thing was after surgery, babysitting of the patient was to be done, and this was done round the clock in 8-hour shift, and that was done entirely by my young team of residents. And here they are; these are the junior most ones. We have Dr. Vidhi, Vamsi, Subhanshu, and Joseph, and they were the ones who did. I think they had sleepless nights all the time. And the batch senior to them, we have Arman, Pavan, and Raghav, and it is essential that without them I think none of all this is possible. And so they worked as a team, and mixing and matching what they did, but they made sure that everything was always right. I think they were more like brothers and sisters for this patient, because at no time did I ever feel that the patient lacked anything. At this time I must tell you that this patient did not have any family members. He had just a father, an elderly father, who was really not, truthfully speaking, willing to run around too much. Also, though they were told that there would be a lot of financial, in the sense there are quite a lot of things that need to be bought from outside. But finally, when it came down to surgery, after that it was only us, and we took care of everything because he sort of put his hands up. It was only 3 days later when his brother came down, a young brother, 2 days later, that things became slightly, I can only say slightly easier for my residents, because even then a lot of running around was done by them. Later, dressings were always done by me, and therapy was done by our occupational therapist and the physiotherapist. Here we have Dr. Bharti from the physiotherapy department, Dr. Shilpa Shri from the occupational therapy, and Dr. Vejanti. Dr. Vejanti continues to take full interest in our patient, and she is the main therapist right now for our patient. She is from the occupational therapy department. At that time, I think for almost 2 to 3 months, our therapist also visited our patient on Sundays also to make sure that the therapy was given, because we did not want to miss out at all on the therapy. Therapists also had virtual meetings with some centers abroad to be able to understand how they can bring this patient to function faster. And throughout this whole tough phase, we kept his morale high. Now, I mentioned financial matters, and there were genuinely a lot of issues. One was finances were needed to travel and bring the limb back from that hospital. Cross matching was to be done at Hinduja, and literally, I must say that each spot at one resident or a staff of mine has gone to that hospital, got the job done. At that time, spent their own money, whatever was needed, but everything was done for this patient without batting an eyelid. And it was only much later that all the reimbursements were done. But at that time, all the running around was done by all our residents and staff. Tata Hospital was very kind. After the first 5 bags of blood were given, irradiated, and we had to pay for. 2 days later, I spoke to them that this would be needed, and they made it free. All the irradiated blood was later free for this patient from Tata Hospital. So that was another. So I think it is possible for us to treat the poor. I know we put in a lot of effort, but then finally you have the satisfaction of knowing that you have done something for them. Even the investigations that were done outside at that time, the lab person, through our residents know them, and they just got it done, and again their payment was also done at a much later level. Patient had arranged for funds through the Madhya Pradesh Chief Minister's funds, but finally a lot more expenses were there. So we did arrange for financial help through, I must say, a lot of my friends came forward, my family came forward. We also had philanthropic individuals who went ahead. Literally, I just had to tell one person, and he gave a check of 1 lakh for this patient. My brother pulled out the same amount. Somebody else did, and we managed to keep the patient going, because this patient needs to take drugs all his life. For that, he says he does have, but at that instance, when we had a very tough time going on with the patient in the beginning, we had to arrange for finances. And I must say that I'm sure that in the world there are enough people who are ready to help when help is needed to be given. And KEM Hospital PBCF itself gave a large amount of help. I'm now going to show you a few glimpses. Up to now I've only been talking and showing you written matter. And here is our patient, and this is literally just before the surgery. We had one more counseling session in the end, and here you see the lead surgeons. Me and Dr. Venkat were the lead surgeons, and we have Dr. Raghav also with us here, my lecturer, who was directly assisting me, and there were some more surgeons. So this is the patient and his father. We had a very, very detailed conversation just before the surgery, and as is usual, finally it is always Bhagwan pe chhod dete hain aur aap pe chhod dete hain, which is what they did, and you can see that action in the father. So that doesn't just happen in films, let me tell you, it very much happens in real life also. You are all going to see that in life. That's us. And while my team had gone for retrieval, this is Dr. Brahma and Dr. Krishore, our assistant professors, who went ahead for the retrieval. At that time, we went ahead and started doing the dissection of the actual stumps, so that we could dissect and keep everything ready. Once that was done, here you can see me doing dissection of the limb when the limbs were here. And again, this was done in the OT. We have 3 operation theatres which are side by side. In one OT, we had the patient. In the other OT, we had taken the limbs. So once the patient's limb was dissected, after that, this limb was also, the limb that had come from there was also dissected. And here you can see the other one being dissected. Finally, this is the hand that was all ready with all the structures, and exactly like we had done in the cadaver. I've shown you this photograph, and this is the one in the donor limb. Everything is ready. You can see the bones have been readied for fixation, and here we are sitting and now putting everything together. You can see how it is not something to be taken lightly. You can see the amount of blood that is there once the the tourniquet is released. There is this. All this time I had shown you my residents' photographs, so there were very few of them. You can see them laughing ahead. Very few of them got a chance to actually assist. Some of them did, some of them did not. But at no time did anyone say that it's 24 hours, we have not slept. I had myself being there from 4 a.m. the earlier day, I think 11 a.m. And I don't know, we finished probably the next day at about 4:30 in the morning. Because we started only 12 hours, like we started only at some 1:32 in the afternoon by the time we finished. But I don't think you can see sleep in anybody's eyes, all these people, and they were ready at all times to run around and do whatever is needed for the patient. So we finished at whatever 4:30 a.m. or something. I think some of us went home, sort of freshened up, and were back in the department. Back in the department by 9 a.m. I guess. Patient was fine, everything was going okay. But next day I thought, okay, now hopefully I will sleep. And at 1:30 a.m. I get a call from my lecturer saying that patient's BP has suddenly shot up. So now there are a lot of changes that happen in these patients, because this is not just a simple surgery. Along with the surgery, there's a lot of drugs which have been given to make sure that the body doesn't fight off the limb. So there are all those immune suppressants which have been given, and those are all very high dose. So it was back again. We all trudged back at 4:35 in the morning. Took the patient back in the theatre, and again by 10:30, 11, everything was fine. And here is the team again. Again, I must tell you, we had hardly slept for like I don't know, 2-3 hours, if at all, in the last 48 hours. But here we are, and again I don't know whether anybody really looks very tired. So that's our team. That's the surgical, the main, the faculty. That's me, Dr. Venkat, Dr. Chandrasekhar, my associate professor, Dr. Raghav, and Dr. Nilesh, my assistant professors. Here's the patient now in the ICU. Now I can show you something else. You see this structure here? Yeah. I don't know how many of you recognize. It's an air filter. Well, these were COVID times. You can imagine we have operated this patient during COVID times in the month of August of 2021. Things were not that great even at that time. The second wave was just barely getting over, and in all that we had operated him. You can see that instead of wearing an oxygen mask, the poor boy is actually wearing an N95. We did give him oxygen at times, but this is a little later. So this is an air filter, and we actually, Dr. Brahma went to Chroma, I think, picked up an air filter. So there's a lot of things that we did for this boy to make sure that things go well for him. And his saturation you can see on the operated hand. Here is the pulse oximeter, and you can see that the saturation is good at 100. We also tried to bring his morale up. This is 4 days later. He was operated, I think, on 12th August, and 15th August was Rakhi. I got 2 Rakhis autoclaved and put it on him. And I told him that now... So I did tell him that now the whole department was his sister or brother, whatever you want to say. But basically he was bound to take care of his hand, because we had done everything to give him that hand, and that it was also his responsibility of. So this video was a little long, and if you actually hear, I was giving him some gyan about the fact that he needs to exercise later. This was just 4 days after the surgery. So this is our Dashera celebrations, and he actually did all, he did the puja and things like that with us. So we've done that. I've done that with other patients also, especially patients who stay long. They feel very good if you make them feel one of you, and it's not like you're the patient, I'm a doctor. So it's it's not like that. We do include them in our department celebrations at times. We also got him immunized because for some reason he had not got himself immunized up till then, which made us really unhappy. But because he was already on immune drugs by that time, we had to wait some time. So this is him getting his immunization. And our dean, then dean Dr. Hemant Deshmukh, and our AMC, Mr. Kakani, had also come to visit him once. Our dean had been highly supportive throughout. I must say that throughout, for every need of his. He said that whatever you need, let me know, and we'll see to it that it gets done for him. So they also, and they were very, I think they were very kind about this, that they waited a long time because of him being on very high immunosuppressants. We had kept him separate, so we were not very happy for visitors. So we had not allowed any visitors, because this was news for KEM and for BMC, but nobody came, no politician, no one came to visit, simply because we could not allow them near a patient who was on immunosuppressants, on high immunosuppressants at that time. So here, this video you see, and this is the young boy. This is the first time that he wrote, and he felt really happy writing the book. And these are finer movements that he's doing. This is a little later, 3 to 4 months later. He's able to now use the scissors, and he's able to brush his teeth by himself. These are the exercises that he does in the occupational therapy department, and you can see by and by he's getting finer. He's able to hold things much better, and finally he's able to remove a mask. He can wear and remove a mask by himself. I think in today's day and age this is really important for a patient, and he's able to eat. So now when you see his eating, I saw his videos, and you're saying when you see him eating, this is one of the early phases, and you see he's bringing his head to the hand, right? And it is not that easy to hold. Little later, this is a month or two later, and now he's able to even pick up chips. Not that easy to hold something fine, and he's able to pick up a chip, and his hand is not that close. And much later, you can see he's eating like any normal person. And these we videos are not taken by us. So it makes a lot of difference when his brother takes the videos, when he's much more natural. The green ones were taken by us. This is it. So I feel that this statement is very true, that when your desires are strong enough, you're going to have powers to do everything that you want to do. And the Josh has always been high in our department. There are many more here in my department. The lecture is not over. But there is more to come. So I think you will ask as to why is it that we in our department felt that we must go so much and do so much for the patient and not just do the surgery. Because as a team, we understand that it is not just about the surgery. It can never be just about the surgery, right? So as reconstructive surgeons, we do a lot for our patients, but what we may think is good is not essentially that the patient thinks is good. So we have to do a lot more for the patient. So when we talk of health, there is physical, emotional, social, spiritual and intellectual. Everything is health. So when we take care of our patient, we have to be holistic about the care, and hence there's a lot more that needs to be done. So what is it that we offer at KEM? We try and offer emotional, psychological counseling. We try and help our patients financially. We try and help our patients vocationally, and we try and also help our patients socially. So these are videos and photographs from a burns ward. I don't know how many of you know, but burns mortality is very high. That's one thing. Try and imagine if 30, 40, 50% of your body surface area is burned. How painful it would be. Many of you may have got scars or touched during in the kitchen. Imagine 40 and 50% of your body burned. It's a tough time. So for all these patients, it is very important that we take care of pain also. So you see this, there's a TV inside, and when dressings are done, my residents try and make sure that the TV is on with some cartoons so the kids are happier. All the kids are also given some books to paint on. I also try and see to it that every child who is a survivor and goes home actually gets some present from us. From NGO's point of view, because we get a lot of women burn patients, they visit the patient in the ward and try and see if there is any way that the patient, the lady can be helped, the survivor can be helped. We do a lot of low cost exercises also. This small board has been made by us, so the patient can do all activities of daily living in the for the exercises. It is not essential, therefore I say that you have everything which looks very fancy or very great. What matters is that we provide the service. And financial assistance is very, very, very important. So there we have our social workers. We are very fast to basically refer our patients to social work and create something called a cost certificate so that all our patients can be helped. From post-healing management point of view, whatever counseling we can give, we give. We also run something called the Burn Survivor Camp. It's a pediatric burn survivor camp. This is the first and only survivor camp of the country. In fact, it's the only one of its kind in the subcontinent. There are very few across the world, and so when you see this girl over here, she doesn't have any fingers. She's got bad scarring on her face, but she has the confidence to be able to present herself in this manner. So when children of a similar time, all these kids who have survived burns, who have got large amount of scars on their body, and they are actually, when they are in society, they have a lot of inferiority complex and lot of problems. When they all come together, they feel so much more confident because they realize that there is someone else like them. So I think this kind of thing is also very important for our patients. And here you see this is our 6th camp. That was the last one. Sadly, after 2019, we were not able to do in 2020 and 21. You see the little child below with pink balloons, and you realize that he is a double amputee, right? And he is waiting for his transplant now. This little child is very confident, and just every time he meets me, I have never seen a child with a bigger smile, and he continues to keep his head held high, but he is waiting for his transplant. What are the other things we do as a unit? We also go for outreach facilities. We are volunteering our services to a lot of villages, to smaller places. There's something called the Lifeline Express. This is a train bogie in which there are actually 2 operation theatres. It can go to the remotest of places. In fact, a few people from our unit have just come from Jagdalpur, which is very, a lot of Naxalite issues are also there in that area, but they have just gone there, and 4 of them have offered services there and come back. So these are some of the things, other things also that our department does. So I must say that along with the surgery that we do, like I mentioned, financial support, vocational, psychosocial rehabilitation, all this is important. So just calling ourselves resource constrained is a very poor excuse for not providing a very good multifaceted care. There are enough resources, there are enough philanthropic individuals in India who are willing to help if only we take the trouble to reach out to them, and we need to draw their attention to our causes so that we can do what we want to for our poor patient. So I think live your passions is what I will say. If you want to do something for your patient, or in fact, if you want to do something anyway in life, please live it, because it is only within yourself. If you believe in yourself, you will be able to find the strength to do whatever it is that you want to. But even if Richard Bach says that you're never given a wish without given the power to make it true, but you have to work for it. So you can't just say, oh, मुझे wish है और मुझे करना है, हो जाएगा. It doesn't happen. We have to essentially work for whatever it is that we want to do. So here is Team Hand Transplant, KEM Hospital, Mumbai, and I would like to thank each one of them. There are many more actually in the team, but at that day for the photograph only these many were there. With dreams of new peaks to scale, I'd like to show you one photograph of peak of what more can be done. And this is us practicing for face transplant. I leave you with this last video where our patient of the hand transplant is paying homage to a memorial which is in KEM for donors. Thank you. Here's our patient. Thank you, Rahul. आपको कुछ बोलना है? उनको सुनना है आपकी आवाज़. आ जाओ. हाथ से क्लिक कर दो. हाथ से क्लिक कर दो. बोल. मास्क निकालेगा? ये ऐसे ही बोलेगा. ऐसे ही बोलेगा. अच्छा नहीं, let him wear anyway. He's a immune.
मेरा नाम राहुल है. जब भी मेरा नाम जब भी एक्सीडेंट हुआ, मेरे दोनों हाथ कट चुके थे फैक्ट्री में, तो मेरा जीवन ऐसा लग रहा था मुझे कि एकदम से ख़त्म हो गई. तो उसके बाद मैं मैम से मिला. मैम ने मुझे भरोसा दिलाया कि ऐसा कुछ नहीं है और अभी भी तुम कुछ कर सकते हो और आगे तुम्हारे साथ अच्छा ही होगा. उसके बाद मेरा रजिस्ट्रेशन हुआ और मैम की मदद से और मैम की उससे मेरा हैंड ट्रांसप्लांट हुआ है. तो उसके बाद मुझे लगा कि हाँ, और मुझे लगा कि अब मैं कुछ कर सकता हूँ और मेरे जीने का कुछ इच्छा हुई और अभी मेरा हाथ अच्छे से काम कर रहा है. मैं इससे खाना खा सकता हूँ, लिख सकता हूँ और नहा सकता हूँ. अपने जो दैनिक लाइफ के काम हैं वो कुछ हद तक कर सकता हूँ और आगे भी मुझे लगता है कि हाँ, आगे मैं बहुत कुछ कर सकता हूँ.
He's wearing a splint because the small muscles of the hand have to get recovered. So he has full sensations now, normal sensations, he says. All the sensations, the full sensory recovery has happened. And he yet has to have recovery of his small muscles, which are the fine muscles. So those are, therefore, so he's got something what we call a claw hand. You know, the fingers are slight. So you learn that in your anatomy very soon. I'm not sure whether have you gone through upper limb anatomy? Yeah, so you will, so please at that time remember to know what are the small muscles of the hand, how they function, and the minute the small muscles recover from a claw hand, he will go on to become a straight hand. Thank you so much for listening so patiently.
Hello. It was way back in 1963 that I sat on this bench today as I sat in the same way. That time it was physiology lecture theatre, anatomy lecture theatre was the other side. And then in 1970 I joined this department as anatomy lecturer, and then when I was asked to deliver lecture, there was no mic, nothing. And there were 160 students. I don't think there are more than that at the moment. And imagine speaking to this large audience and no mic. So this, I think once we will spend some time together, that how this lecture theatre itself has evolved, I will be able to tell you from 1963 till to date. I am extremely pleased that Dr. Vinita Puri has done a wonderful job for introducing right at first MBBS level how to make a humane physician. Thank you so much. See, technique will give you big name, but along with technique, humane approach will give you that inner sense of fulfillment, which Mercedes, Jaguar, huge bungalow, farmhouse, private jet, private boat, nothing will give. What gives you when you can establish rapport with everybody else on one-to-one basis. And this is the idea. I'll just tell you a few things. Dr. M.V.L.Kothari, as this known chair, he has spoken in this very theatre. He was the staff member from 1963 till 2000. Of course, retired as professor and head of anatomy department. And all his students, maybe I do not know, some of your parents might have heard him, if anybody's parent was here at GS Medical College. And they say that we do not remember what sir, other teachers taught us about anatomy. And Dr. Manu Kothari never taught us anatomy, but we till today remember what he taught us. And he made everybody appreciate what it is to enrich oneself, whereby you pass on your enrichment to everybody else. Please note, each one of you is a wonderful person, unique. I don't know how these students picked up that small clip. I believe in this, that start looking at everybody else as your friend and not as a competitor. And make yourself so relaxed. Make the best of your the student days and have happiness about being yourself. Not in comparison with anybody else, but being yourself. And this is what we are trying to do through our Division of Humanity. And M.V.L.Kothari chair, of course, is the pioneer. And I want you to learn to smile whenever you meet anybody else. And I'm sure you will get more and more out of this. And you can always join us and we can make GS Medical College, KM Hospital, a better place for everyone. Thank you very much.
So now I would request Rupa ma'am to present the token of appreciation to Dr. Vinita ma'am. Thank you ma'am, it was nice to have you today. Before closing the session, I would like to introduce you all to my team. Rohan, as you know, he introduced himself. Then we have Julie, Ria, Sharvari. We also have Kiran and Palak. Currently, she's not here, but definitely it was a wonderful event, and we were pleased to have you all, as it was a offline event after such a long time, and you guys were absolute wonderful audience for the session. Thank you for having us today, and thank you for being here today. I'll just end by telling you all that we are having a recruitment process currently for short courses and Ascension, and the date has been extended till 2nd of May. I would like you guys, those who are interested, to fill the form by 12 p.m. till 2nd of May. Thank you guys. Have a good evening.